morning all. The topic is PRRT in neuroendocrine tumor. So, what is PRRT? As we know, it's a molecularly targeted systemic radionuclide therapy. A beta-emitting radionuclide is related to a somatostatin analog peptide, and which is given intravenously. It targets somatostatin receptor, especially SSTR2, which is overexpressed in the surface of neuroendocrine tumor cells. It is delivered for advanced, unresectable, or metastatic neuroendocrine tumor and integral arm of theranostic approach. So, disease background: neuroendocrine tumor is a heterogeneous group of neoplasms which are arising from cells of the endocrine and nervous system. Behavior ranges from indolent to benign to frankly malignant. Annual incidence is almost 50 per million and steadily rising with improved detection. Primary sites: gastroenteropancreatic, GEP-NET, that is almost coming as 70%, bronchopulmonary 25%, and other sites 5%. So, epidemiological data is showing that incidence of neuroendocrine tumors are increasing. Maximum diagnosed cases from gastroenteropancreatic NETs. So, WHO 2019 grading, as we all know, NET grade 1, K67 index less than 3. Grade 2 is 3 to 20%. Grade 3 is more than 20%. And neuroendocrine carcinoma is more than 20%. So, somatostatin receptor. This is octreotide, that is a targeting vector. It's a synthetic octapeptide analog of somatostatin that binds somatostatin receptors. It will be conjugated through a DOTA chelator. It can carry diagnostic and therapeutic radionuclides. The diagnosis is done by gallium labeled DOTATATE PET, or therapy we can plan with yttrium or lutetium DOTATATE. So the shared scaffold is the structural basis of the theranostics in a neuroendocrine tumor. So tumors having documented somatostatin receptor, we can see maximum with the SSTR2 in multiple tumor types. So how PRRT kills the tumor cell in the biological basis, which is by the receptor binding. Radio-labeled somatostatin analog binds to SSTR2 on the neuroendocrine tumor cell surface, then causes internalization. The receptor ligand complex is internalized into the cell, causes DNA damage because of the beta particles from the lutetium-induced single and double-stranded breaks, and also it has got crossfire effect, almost approximately 2 millimeter beta range. So, the radiopharmaceutical is a key log principle which consists of a radionuclide, a chelator, and a cyclic octapeptide. So, why lutetium DOTATATE, which is most usually agent, is a standard and best evidence PRRT radiopharmaceutical, since it emits beta minus for therapy and gamma photons for post-therapy imaging, and it has got a short beta range and also safer profile. And for administration to disease control, lutetium DOTATATE is administered, which is binding to SSTR2 neuroendocrine tumor cell. Then, as I said, internalization, then beta particle emit within the cell, DNA damage, apoptosis, then tumor control and disease stabilization. So, if you're looking at the history, the evolution of PRRT in 1990s, it was initially indium 111 labeled octreotide, which is the first receptor therapy with the proof of concept. Then in 2000, it came yttrium-90 DOTATATE. Then 2017, lutetium DOTATATE came. The landmark trial, which was NETTER-1, it was the first phase 3 randomized control trial for mid-cut NETs. And in 2018, FDA and European Medical Association was approved lutetium DOTATATE. And 2024, after NETTER-2 published in Lancet, PRRT moves first line for the grade 2 and grade 3 gastroenteropancreatic neuroendocrine tumors. So PRRT for net, the first 2 decades, which was first attempted, as I said, in 1990s with the DTPA octreotide. In 1996, the first patient was treated in Switzerland with yttrium-90. With excellent clinical response after few treatment cycles, established the proof of concept. In 2000, it is introduced into clinical use, followed by the lutetium. So let's see patient selection and treatment delivery. So SSTR imaging and screening score. Screening score has got 4 scores. One is 0, is no uptake. And grade 1 is very low, which is less than the uptake is less than the normal. And 2 is moderate, which uptake is equivalent to the liver, which is borderline. And grade 3 is high, which is more than the liver. And 4 is very high, which is uptake is more than the spleen and kidney. So grade 3 and grade 4 are eligible for PRRT. So who is an ideal candidate? Well differentiated neuroendocrine tumor with the grade 1 and grade 2 and selected grade 3. SSTR positive disease with the Greening score 3 to 4, then inoperable, metastatic and progressive disease with adequate renal function and bone marrow reserve and good performance status. The caution, one is poorly differentiating neuroendocrine carcinoma that are not suitable for SSTR negative disease, dominant FTG habit of SSTR discordant lesions with low GFR, inadequate bone marrow reserve, such as absolute neutrophil count if it's less than 1500, hemoglobin less than 8, then pregnancy lactation or uncontrolled comorbidities. So renal function, GFR should be more than 40 to 50 ml per minute, HP should be more than 8, and WBC and absolute neutrophil count platelets should be above the protocols. Then adequate liver function and overall fitness. If you see the alkaline phosphatase level, the guidelines recommended that it shouldn't be more than 3 times the normal. The treatment protocol, what we are using is the 4 cycles, each cycle of 7.4 GPQ of 200 millicurie per cycle, 4 cycles for 8 weekly with the long-acting nucleotide for symptomatic control. So renal protection, we are giving lysine and arginine infusion, amino acid infusion. So it start before and continued after. Should be started before 30 minutes of pre-infusion and continued for 2 hours. And it will reduce the renal dose, lowers the tubular retention and long-term nephrotoxicity risk. So let's see how the PRRT came into existence. So first line, it was a potentially resectable disease for surgery and unresectable asymptomatic low burden diseases observation of somatostatin analog. Unresectable or symptomatic disease which was treated with the somatostatin analog plus symptom plus anti-proliferative control disease agents. Then evidence came, that's his first line PROMIT trial with the somatostatin as long-acting receptor as a first-line therapy, which is a phase 3 placebo-controlled randomized trial with 85 patients with the metastatic midgut carcinoid tumor, octreotide long-acting receptor, which is used 30 mg versus the placebo, which established the anti-proliferative role of somatostatin analog. So, second line options on progression were to escalate or switch the somatostatin analogs, which is progression of hormone-related symptoms, or dose escalation of somatostatin analog. Then liver-directed therapy came, transarterial embolization, chemoembolization, then radioembolization, then systemic therapies with the mTOR inhibitor, anti-VEGF, then TKS. So, Radiant 4, which was an international double-blind, placebo-controlled phase 3 trial with the participants of 302 numbers with progressive non-functional lung or GI neuroendocrine tumor. So it was randomization was 2:1 everolimus versus placebo. Here they found the hazard ratio for progression, but it is 0.48 with the everolimus median progression-free survival in months 11 versus 3.9. So then came the landmark trial, which is the NETTER one, which is the phase 3 trial. The first phase 3 randomized controlled trial of lutetium DOTATATE. So study design is a phase 3 randomized trial, which is international, multi-center, with the 41 centers in 8 countries, started from September 2012 to June 2016 as the enrollment period, and 229 patients randomized, midgut net progressive on octreotide. Eligibility criteria, age more than 8 years, metastatic or locally advanced, inoperable, histologically proven midgut NATs, Ka67 index less than or equal to 20%, and progressive disease on a fixed dose of octreotide, and SSTR positive disease. Exclusion, creatinine clearance less than 50 ml per minute, HB less than 8, and platelet count less than 75,000. Then octreotide more than 30 mg within 12 weeks of randomization, or surgery, liver-directed therapy or chemotherapy less than 12 weeks. Right. So experimental arm consists of 116 patients with the lutetium DOTATATE 200 millicurie, which was given, plus the control arm high dose octreotide, which was given as IM every 4 weeks. Study endpoint is the progression-free survival. So time from randomization to disease progression or death. Secondary endpoint, one is objective response rate, which is according to the RECIST 1.1 criteria with the overall survival, safety and tolerability, and also side effect profile. So we can see the progression-free survival in the Kaplan-Meier curve. We can see there is a marked early suppression between the treatment arm and the lutetium DOTATATE arm, which shows increased progression-free survival. So the objective response and the stable disease lesson here. The objective response rate, that is ORR, is 18% for lutetium arm versus 3% for the control arm. So while we can see that this is a modest 18% objective response rate is still matter here, because NETs are slow growing. A dramatic shrinkage is rare, and it is not the goal here. The aim is to arrest growth, not necessarily reduce the tumor size. Long-lasting, stable disease delays progression, controls symptoms, and preserves quality of life. Hence, progression-free survival and disease control rate are more meaningful than the objective response rate alone. So, quality of life, the patient receiving lutetium dotatate showed a meaningful patient-reported benefit versus the high dose octreotide. One is the global health status, delayed deterioration in the overall global health or quality of life indexes, then symptomatic control, then time to diarrhea, longer time before clinically meaningful worsening of the diarrhea, then longer time before worsening of the pain and fatigue. So here, as I said, the objective response rate, which was for PRRT, was 18%, whereas control group it was 3%. So here, while doing the study, many trainees expect PRRT to shrink the tumor dramatically. However, the Netter one proved that only 18% achieved the resist response. So most patients achieved a stable disease. The disease stabilization was responsible for the remarkable progression-free survival benefit. Hence, stable disease, which is not equivalent to the treatment failure. As I said, the quality of life, patients receiving PRRT showed delayed deterioration in the global health status, but symptomatic control, and longer time before the worsening of the diarrhea or worsening of the pain and fatigue. So, and then the overall survival, they did a final analysis in 2021. So, initial publication showed a trend toward improved survival. Final analysis proved a median overall survival for PRRT received patients for 48 months, whereas control group is 36.3 months. The difference was only 11.7 months. So, by here, if we say that overall survival is not significant, because it is only a matter of 11.7 months, which is not statistically significant. As I said, here patients survive for longer periods, diluting the events. Effective subsequent therapies after the progression also, and also approximately 36% of the control patients later crossed over to PRRT, and also insufficient death events for statistical power in the study. So then came the NETTER-2 trial, which is published in 2024, where PRRT is the first line therapy in high-grade gastroenteropancreatic neuroendocrine tumor. So why NETTER-2? The first phase 3 randomized control tried to evaluate the PRRT as first line treatment in newly diagnosed, advanced, high-grade, well-differentiated gastroenteropancreatic neuroendocrine tumor. It is a successor to the NETTER-1. NETTER-1, what we looked, it's progressive metastatic NETs. PRRT used after progression on somatostatin analog, and it is as a second line setting. Whereas NETTER-2, newly diagnosed patients, no prior progression, PRRT moved to the first line settings for biologically aggressive neuroendocrine tumor, that is high grade 2 and grade 3. So design and eligibility. Study design here also is phase 3, open label, randomized, international multicenter. PRRT arm consists of 151 patients, for the control arm with the 75, total 226 patients. Eligibility: newly diagnosed, advanced gastroenteropancreatic neuroendocrine tumor that are well differentiated with the grade 2, grade 3. KS it is 67 index between 10% and 55. Strong SSTR positivity and all target lesions, age more than 15 years. Here the patient consists of 65% with the grade 2 and 35% with the grade 3. Here also lutetium dotatate 200 millicurie was given by the control arm with the high dose octreotide. So major results here the progression-free survival, PRRT plus octreotide, the median progression-free survival was 22.8 months, whereas for the high dose octreotide it was 8.5 months. Here the difference was 14.3 months in favor of PRRT with a hazard ratio of 0.276. So it corresponds to approximately 72.4% reduction in the risk of progression or death. So in NETTER-1, the objective response rate was 18%, whereas in NETTER-2 it is 43%. So clinical significance. So NETTER-1 changed the second line therapy. Progressive midgut NETs to PRRT became the standard after the excessive somatostatin analog failure, whereas NETTER-2 it may change the first line therapy, which is well differentiated grade 2 NETs with high CT7 index more than 10%, well differentiated grade 3 NETs, high tumor burden, SSTR positive disease. Here the PRRT may move from a salvage to an early treatment strategy. So, at a glance, NETTER-1, NETTER-2, it's published on 2017. 2024. Settings NETTER1 after progression, whereas NETTER2 is first line. This is medgut NET, whereas gastroenteropancreatic NET, grade 1 and grade 2, here high, grade 2 and grade 3. Highest it is on less than 20%, here 10 to 50%. Then hazard ratio for progression-free survival is 0.18, this is 0.276. Then ORR is 18% and 43%. So we'll see the response assessment during and after the PRRT. So why response assessment in it is uniquely difficult? Because of indolent biology. Because prolonged stable disease is a favorable outcome, which is not a failure. Anatomic and molecular discordance, the size lags behind the true biological response. The density and which is not the size, necrosis, calcification and fibrosis with a little diameter change. Multi-compartment disease are there because involvement of liver, nodes, mesentery, bone, with all response at a different rates. So the numbers which I mentioned before, that objective response rate, that is the percentage of the patients who had a significant reduction in tumor size according to RECIST 1.1 criteria, which includes the complete response plus partial response. In NETTER, as I said, 18% of the patients treated with the lutetium dotatate achieved an objective response, and 3% of the patients with the control arm achieved an objective response. At first glance, the 18% may seem modest because only about 1 in 5 patients had a measurable tumor shrinkage. And the progression-free survival was, with the hazard ratio, it was 0.18. The patient receiving PRRT had an 82% reduction in the risk of progression or death compared with controls. So why this apparent paradox? Because these neuroendocrine tumors are slow-growing tumors. The major role is often not to shrink the tumor dramatically, but to stop them from growing. So instead of partial response, that is tumor shrinkage, many patients achieved a stable disease. So this prevented the progression for prolonged periods. In NETs, achieving a long-lasting stable disease is often highly successful outcome because the tumor growth is arrested, symptoms may improve, and quality of life is maintained, and the time to progression is significantly delayed, and overall survival may improve. So this is why progression-free survival and disease control rate are more meaningful endpoints than this objective response rate when evaluating a case of PRRTs. So establishing a reference point, initial evaluation with the baseline evaluation before starting cycle 1, we should confirm the SSTR expression, and to map all the disease, establish the eligibility. We can do dual PET with FDG PET CT also, with which can show the unmasked FDG habit or SSTR low disease lesions, and we can stage as net PET grade, and then prognosis and mismatch lesions. We can do contrast CT or MRI for according to resist the target lesions, and laboratory parameters such as chromogranin, renal function, CBC, and baseline dosimetry. So post-therapy, most of the ENM dosimetry guidance is telling for post-therapy, SPECT CT, which is occur 24 hours after each infusion. So which will confirm the target, and it can detect new lesions, and it will give us an in vivo dosimetry also. So there they mentioned something called SUV in quantitative SPECT SUVs with a falling tumor SUV between cycle 1 and cycle 2. One quantitative post-therapy SPECT may predict the morphological response. So restaging between cycles, do's and don'ts. Recommended practice, clinical review and biochemistry at every cycle. Cross-sectional restaging at midpoint after 2 cycles and at completion. Preserve full molecular restaging for completion and equivocal CT. So routine interim DOTATATE PET imaging cycles is not recommended. Transient receptor downregulation and flare can mimic change that doesn't reflect the true response, and don't overcall early size change as progression also. So decision points on interim imaging, if the market response was stable, then complete the planned cycles. New FDG disease appears to reevaluate the overall strategy. Then unequal progression on CT, consider stopping, switching, or adding therapy, and also dosimetry guided adaptation. So here we should be cautious about this flare phenomenon. So after PRRT therapy, lesions can transiently appear larger, more numerous, or more avid before true response sets in. That's a flare phenomenon. So imaging too early risk a false call of progression also. Inflammatory flare, treatment-induced inflammation can increase apparent uptake or the size transiently. SSTR expression may transiently shift, altering the appearance. So practical rule is 12 weeks, more than 3 months minimum interval after the final cycle before interpreting follow-up SSTR PET as for response. So post PRRT, post therapy expect in each cycle. In 2 to 3 months, if we want, we can do a cross-sectional imaging, and at 6 months confirmatory staging. Then every quarter we can do surveillance and individualized long term. And there is no hard and fast rule here. The physician can take the call. If physician is feeling that the disease is progressing after 2 cycles, he can do a functional imaging. So anatomical response, RECIST 1.1 just mentioned, the RECIST 1.1 with the categories. So, and then dual tracer imaging, the flip top and net pet grade, we know, grade 1 with the DOTATATE ability, and the FTG ability is less. Median overall survival is 102 months, which is having the best prognosis, whereas 2 to 4, whereas DOTATATE habit, FTG habit, median overall survival is 47 months, whereas grade 5, where SSTR ability is less, whereas FTG ability is more, the median overall survival is 12 months. So biochemical response, chromogranin A we can do, which is most used generally in neuroendocrine tumor marker, which can trends can support imaging but are just non-specific, which can be affected by PPS and renal and liver function. Then in carcinoid syndrome, we can use 5-HIA and insulin or gastrin for a functioning tumor, and the mRNA test, and also clinical response also we can document. So what was done in Nectar 1 and Nectar 2, and the baseline, they are done SSTR imaging. Some places an Octrio scan, some places done a gallium DOTATATE PET to confirm the receptor positivity. And during the treatment, they followed RECIST criteria, CT and MRI every 12 weeks. After the treatment, they continued CT and MRI based on RECIST follow-up. DOTATATE PET CT was not done daily. So current practical guideline, which was seen in North American Neuroendocrine Tumor Society. So before PRRT, what they recommended to do a contrast CT or MRI, and mandatorily we should do a DOTATATE PET to see the ability, and FDG PET CT if it is a grade 2 or high index Ki-67 index of grade 3 native or aggressive disease biology if suspected. So during PRRT, after 2 cycles, so they given the call to physician. Physician can decide whether to do a functional imaging or perform a CT MRI, or if there is a clinical deterioration or suspected progression, or if it is a mixed response. So needs to decide whether to continue the treatment or not. So when should we repeat? So suspected progression on CT or MRI, if there is a discordant in an anatomical finding. So when considering pre-PRRT treatment and assessing residual receptor expression before salvage therapy, or if we found a change in the tumor biology. So in summary, lutetium-DOTATATE PRRT is an established standard therapy for progressive SSTR positive neuroendocrine tumor based on the landmark NETTER-1 trial. In NETTER-1 trial demonstrated 82% reduction in the risk of progression or death with improved objective response rates and quality of life. NETTER-2 expanded the role of PRRT to the first-line setting, showing significantly prolonged progression-free survival and higher response rates in selected high grade 2 or grade 3 well-differentiated gastroenteropancreatic neuroendocrine tumor. The principal benefit of PRRT is durable disease stabilization rather than tumor shrinkage alone. Therefore, the RECIST response rates may underestimate its true clinical value. With the favorable efficacy, the quality of life benefits, and an acceptable safety profile, PRRT remains a cornerstone of modern multidisciplinary management of neuroendocrine tumor. So, neuroendocrine tumor, the success of PRRT is best measured not only by the tumor response but by sustained disease control, delayed progression, and improved patient outcomes. Thank you.